Today we're going to talk about management of hyperkalemia. In terms of management of hyperkalemia, make sure you do get an EKG because the EKG may show effects of hyperkalemia such as hyperacute T waves, narrowed peaked symmetrical T waves, followed by reduced P wave amplitude and also widening of the QRS complexes. For management of hyperkalemia, it's very important to know if it was chronically elevated or was it a rapid rise. For example, if it was a rapid rise, this would result in emergent management of hyperkalemia, such as young trauma patients with crush injuries versus someone with chronic kidney disease who has elevated potassium levels chronically. So the management may be variable in terms of emergent versus non-emergent based on the rapidity in which the potassium levels have risen. In terms of the levels, we mentioned that mild hyperkalemia is somewhere between 5.5 to 6. Anywhere from 6.1 to 7 is moderate hyperkalemia, and anything above 7 is considered as severe hyperkalemia. Now you have obtained the EKG, so the first step would be to administer IV calcium. Now how does it work? It antagonizes the effect of hyperkalemia on the myocardium. It takes about 1 to 3 minutes to act, and the duration of effect of calcium is about 30 to 60 minutes. If the EKG changes have persisted, you can always do the calcium gluconate again. Now step number 2 is give insulin with glucose. The insulin is going to be 10 units of regular insulin given IV. It's very important to know the dose and the route, because this is going to be 10 units is going to be regular insulin, can't choose another form of insulin, and contradictory to how we treat diabetics, which is subcutaneous insulin, this is going to be IV. The onset is about 20 minutes and the peak effect is in 60 minutes, and the effect lasts for 4 to 6 hours. Now, many patients may have hypoglycemia, so make sure you give dextrose with it. This is going to be D50, not D5, not D10. It's going to be D50 dextrose. Now, the other step would be to identify and remove the causes of potassium levels. For example, if it's anything oral medication, that should be stopped. It was parenteral potassium supplements that can be stopped. Now, the insulin has only shifted the potassium intracellularly. So how do we get rid of this extra potassium? Now that can be in the form of a diuretic. Use a loop diuretic or cation exchange resin, or the other form which would immediately correct this hyperkalemia would be dialysis. In terms of the other medications, make sure the patients are not on any ACE inhibitors, ARBs, or aldosterones, or calcineurin inhibitors, any other medications that can cause hyperkalemia. Regarding dialysis, remember to say dialysis only when your medical options have failed, or is it someone with severely elevated, rapidly rising potassium. But usually in the exam, they want you to mention every other treatment, because the role of dialysis is correction of hyperkalemia, which is resistant to medical management. So that's the right answer, resistant to medical management. So you have to prove that the potassium was not corrected by other parameters. Before you give loop diuretics, make sure the patient is making urine. Some patients with acute renal failure may not be making urine. So in this case, a loop diuretic may not be the right answer because they are not making urine. Now, in terms of GI excretion of potassium, remember that 90% of potassium is excreted in the urine. So only 10% is secreted in the stool. However, if the patient has chronic kidney disease, they have developed complementary mechanisms where they are able to excrete more potassium through their gut. Anyways, it's important to know that normal potassium excretion is in the urine and not the gut. In terms of the options available for the gut, for GI excretion are three. I'll mention you the names. One is sodium polystyrene sulfonate, which is Caxolate. The other one is Peltiromer Veltassa, and the third one is sodium zirconium cyclosilicate. This is called as Lokelma. One of the side effects I want to mention you for the Caxolate is important for surgery boards is that it can cause ischemia and necrosis of the bowel. So in patients who have very dilated colon, may cause ischemic injury to the bowel. This can be a side effect of basically all the GI cation exchange resins. I would repeat again, in terms of management of hyperkalemia, again, make sure you know what the cause is, remove that source. If it's a rapid rising hyperkalemia, you have to do the emergency medicine. If there are patients who are chronically elevated, such as chronic renal failure patients, they may remain in hyperkalemia in normal phases anyways, so you don't need to urgently treat them. But if it's a young trauma patient with crush injury or a AAA repair, and all of a sudden the potassium is 6.5 or 7, these are all urgent indications for treatment, which would be EKG, calcium gluconate, insulin, followed by removal of the etiology, followed by loop diuretics if they're making urine, or consideration of GI options, or also in urgent cases, remember the GI options take time to relieve. The onset of action is around 7 hours to 2 hours, so they would take their time, and the reduction of potassium is only 0.14 to 0.2, so that's not going to be a huge reduction in potassium after you do the GI options. They're used more for chronically elevated potassium, so that your go-to option would be dialysis, but make sure the examiners know that before you are going to dialyze the patient, you have exhausted your medical management of hyperkalemia. Thank you.